Hi everybody, Dr. Chitra here, your mentor at StudyMEDIC and StudyMRCOG, and the topic for the video today is the module Urogynecology. So objectives of this video: to understand the lower urinary tract symptoms, pathophysiology, management and the urodynamic graphs, then management of pelvic organ prolapse, understand the POPQ system, and post-hysterectomy vault prolapse. So let us begin. I would also be discussing a few important questions that would be asked in the exam. I want you to pause the video here and think about the definitions of overactive bladder, detrusor overactivity, urodynamic stress incontinence, and pelvic organ prolapse. Alright, so here are the definitions of all these conditions. Please go through them very carefully. Now, first let us start discussing about detrusor overactivity. So detrusor overactivity, we know it is characterized by involuntary bladder contractions. So the woman would present with symptoms of urgency, frequency, nocturia and urge leakage. Cause of this most of the times is not known. It could be due to neurological disease or even sometimes due to urethral obstruction. Investigations done as a general rule for any woman who presents with LUTs. First is urine analysis to exclude UTI. In any woman complaining of any voiding dysfunction, always a post-void residual is done. And how do you do this? So you ask the woman to void and then you measure it with a portable bladder ultrasound scan. Or you can also put in a simple rubber catheter, but it is usually avoided because it can potentially lead to infection. Whenever the PVR is more than 100 ml, it's considered to be abnormal. Women, those who come with symptoms of detrusor overactivity or overactive bladder, ask them to maintain a bladder diary, which is basically a frequency volume chart, which is maintained for 3 days, 2 days of her work life, 1 day of rest. So you know the amount or the type of fluids that she is drinking, the number of voids in the day, the volume of each void, and whether it is associated with a leak or not, and the type of leak, whether it is on straining or it is urge incontinence. The last investigation that is offered is urodynamics. So this basically tests the bladder and urethral function. Different components of urodynamics are uroflowmetry, cystometry, video urodynamics, urethral pressure profile, and ambulatory urodynamics, which are rarely done. Let us first see uroflowmetry. So this is a typical bell-shaped graph in which the flow rate is plotted against time. So Qmax, or the maximum flow rate, should be more than 15 mL per second, and you get this bell-shaped graph only when the volume of urine is more than 200 ml. So what would an abnormal graph look like? Here you can see that Qmax is significantly reduced. It is 7 mL per second, and the voiding time is also increased. So this could happen either with obstruction or it could be due to a hypocontractile bladder. In this graph you can see that flow is intermittent. This is classically seen with obstruction. Now these are some urodynamic graphs. So remember, in the urodynamic graphs, 3 lines which are very important. The lowermost is detrusor, which indicates the detrusor pressure. This is the abdominal pressure and this is vesical pressure. Whenever there is a leak, it is marked either at the lowermost part of the graph or it could be marked here, and it is marked very clearly as a leak. Remember, this is the filling phase of the graph. So what are you seeing in this graph? Detrusor pressure is stable, that means there are no detrusor contractions. There is an increase in the abdominal pressure as well as the vesical pressure. So what does this indicate? Remember, detrusor pressure is not increasing. There is increase in abdominal pressure, there is increase in vesical pressure, and at the same time you are getting a leak. So this is classically what is called as urodynamic stress incontinence. The detrusor muscle is not contracting. In spite of that, there is a leak. So this is urodynamic stress incontinence. Now what is happening here? Let us see. The detrusor muscle is showing some contractions. Abdominal pressure is remaining stable, and because of increase in the detrusor pressure, the vesical pressure is also increasing. So this is classically what is called as detrusor overactivity, because remember, in the filling phase, the detrusor muscle should not be showing you any contractions. Now, whenever the detrusor muscle is showing contractions and at the height of a contraction you are getting a leak, this is called as urge incontinence. Okay, so you are having an urge incontinence here. If at some point in the graph you see that there is no increase in the detrusor pressure, but only the abdominal pressure is increasing and the vesical pressure is increasing, and without a detrusor contraction you are getting a leak, then it would be called as mixed incontinence. Let us come to management of overactive bladder. Remember, in UK or in NHS, the initial management that is done is always conservative management. So ask the woman to make some lifestyle changes. Her fluid intake should be 1 to 1.5 liters per day. She should avoid any caffeinated drinks, avoid alcohol. If BMI is more than 30, encourage her to lose weight. Modify her drugs. So drugs that affect her bladder function like diuretics or some antihypertensives like doxazocin, these should be changed. If the woman is in the perimenopausal or postmenopausal age group, offer her local estrogen therapy, because this improves the urogenital atrophy and makes the symptoms more easier to cope. The last is bladder training. So this is offered for about 6 weeks. If bladder training does not help the woman, the next line is medical management in the form of antimuscarinic drugs. So drugs that are offered commonly is oxybutynin, festoredin, propiverin, solifenacin, tolterodin and trospium. Commonest drug to be used is oxybutynin. Remember, with oxybutynin, avoid it in frail old ladies, and there are a lot of side effects with oxybutynin, mainly blurring of vision, dry mouth, constipation, decreased libido, and most of the women stop using the drug because of the side effects. If the woman does not respond to your antimuscarinic drugs, the next management is mirabegron. This is rarely offered. This is basically a beta-3 adrenoceptor agonist. It leads to detrusor smooth muscle relaxation. This also has a lot of side effects like nausea, dizziness, palpitation, headache. Important thing to remember about mirabegron: avoid it in patients those who are hypertensive. If none of these conservative management or medicine is helping her, the next modality is intravesical botulinum A. Now this is given only after a multidisciplinary team meeting and after explaining to the woman that intravesical botulinum A could sometimes lead to urinary retention, so the woman might have to do clean intermittent self-catheterization. Only if she agrees to this, then botulinum is given. Initial dose is 100 units. If the woman does not respond to 100, it can be increased to 200 and repeat injections might be necessary. If botulinum also doesn't help her, the next is percutaneous sacral nerve stimulation. If this also is not working, then reconstructive surgery in the form of bladder augmentation or augmentation cystoplasty or urinary diversion. With augmentation cystoplasty, remember, it is a part of the ileum that is put into the bladder, so that can lead to mucus formation in the bladder, or sometimes there could be malignant changes. Remember this hierarchy and do not mess it up. The management should always go in this way from 1 to down below. Okay. Next, management for stress incontinence. As always, conservative management first, weight loss. At the same time, you can offer her pelvic floor muscle training. This is offered for 3 months. The woman has to do 8 contractions 3 times a day. Vaginal devices in the form of pessaries can be offered. These are specially offered for women, those who have not completed their family, because if you offer surgery, and in the event of a pregnancy, again, the benefits that are there with the surgery could be lost, or pessaries could be used to buy some time in women, those who have medical comorbidities, till you optimize their medical condition. Duloxetine is offered only if surgery is not acceptable to the woman and she is not responding to conservative measures. Surgery is the last option. The gold standard these days is birch corpus suspension, or you can also offer slings, either autologous rectal facial slings or retropubic tape procedures with other slings, or you can offer intraurethral bulking agents. The slings that are used are made of synthetic material. Now let us see a few questions that could be commonly asked. So pause the video here, read the question very carefully and then come to the correct option. So the correct option here is cystoscopy. Why is it cystoscopy? Understand that here you have a 60-year-old woman who is coming with some urinary symptoms, but in addition to that, her urine is showing RBCs and leukocytes. Okay, ideally it would have been the urine already has been done. Microbiology is not really going to help you because it is showing RBCs. So whenever RBCs are seen, always think of any sinister change, and to rule out that sinister change, cystoscopy is always advised. Any woman showing hematuria, please choose cystoscopy as the first option. Now let us see this urodynamic graph. Pause the video, have a look at the graph very carefully and see. Okay, so this woman, she has complaints of urinary urgency, frequency, and she is also having nocturia. So what could be the likely diagnosis here? She has no urge incontinence or she has no stress urinary incontinence. From her symptoms, it looks like she has overactive bladder. Okay, now if you have a look at the graph, you can see that the detrusor pressure is rising. Okay, it is showing, this is the red line is the detrusor pressure, the blue line is the abdominal pressure, even that is rising, and this is the detrusor pressure, this is the vesical pressure, and this is the abdominal pressure. So because the detrusor pressure is rising, the vesical pressure is rising, but there is no increase in abdominal pressure. So the diagnosis here is it is detrusor overactivity. Okay, there is no incontinence, no leak is marked, so it is not detrusor overactivity incontinence, it is only detrusor overactivity. Whenever you see that there are contractions in the detrusor muscle, it is always detrusor overactivity. It is not overactive bladder because this is a urodynamic diagnosis. Okay, pause the slide again, read the question very carefully. So you have this young woman, okay, she has just delivered 2 months ago, family is not yet complete, okay, and there is no stress urinary incontinence. And what is she complaining of? What would be the next appropriate management for her? Because she is complaining of urine leakage only on running and exercise. The correct option here is supervised pelvic floor exercises. Why? Because she is complaining of stress urinary incontinence. She is a young woman, just delivered. She is planning for another child. So you do not want to offer any surgery for her. And she doesn't have any symptoms of overactive bladder. Okay. Urodynamics is something that would be offered only if you are planning for a surgery or there are specific indications for urodynamics. Bladder training is not an option because she doesn't have symptoms of overactive bladder. Topical estrogen therapy not indicated because she is a young woman. Duloxetine is not routinely offered. That leaves us only with supervised pelvic floor exercises, which really makes sense because she is a young woman, just delivered, and she is giving history or she has symptoms of stress urinary incontinence. Alright, now another 50-year-old woman undergone surgery for SUI and she has come back again with complaints of incontinence when she is coughing. What else? What would you do for her now? Is PFMT going to be of help? No. Colposuspension, she has already undergone some type of surgery. Sacrocolpopexy doesn't make sense because she doesn't have symptoms of vault prolapse. That leaves us with the option of urodynamics. So what are the indications to do a urodynamic study? The guideline clearly states you will offer urodynamics to any woman who has urge predominant mixed urinary incontinence or urinary incontinence in which the type is unclear. She has symptoms suggestive of voiding dysfunction. There is anterior or apical prolapse, or there is a history of previous surgery for stress urinary incontinence. So this woman fits into this last category. So that is why urodynamics is the best option for her. Now another lady presenting with urgency frequency nocturia. She has both urge incontinence and stress incontinence. So what would you offer her? Remember, she has symptoms for both. So it makes sense that you should be treating both her conditions, and option E is the one that fulfills both. So you are offering her pelvic floor muscle training as well as bladder training. The guideline says offer treatment for the symptoms that are most predominant, but here they have not given which is the predominant symptom, and you have a very good option in the form of treating both her symptoms of overactive bladder as well as stress urinary incontinence. Alright, now stop the video here again, pause it and read the question very carefully. So 84-year-old woman, sometimes coming with history of urinary retention. She has second or third degree vaginal vault prolapse. She has uterine prolapse, anterior and posterior. What would you give her? The correct option is insertion of a shelf pessary and booking pessary replacement as usual. Why pessary? She is 84 years old. Okay, surgery would not be a very good option at this age, and she needs some form of treatment immediately because she is complaining of retention of urine on and off. And 84 years old, she would not be sexually active, so insertion of a ring pessary doesn't make sense. You can offer her a shelf pessary, and whenever a pessary is inserted, the woman is always called back for replacing the pessary. Going ahead in the same scenario, this woman, she had a shelf pessary inserted, and after 2 weeks she comes back with some mild discomfort and she says she has some blood-stained vaginal discharge. When you examine her, you found that she has a vaginal ulceration in the anterior vaginal wall. What would you do? Think. So, you will not insert the pessary for her now. You will use local estrogen cream and book another appointment in 2 weeks to reinsert a new ring pessary. Okay? Remember that vaginal ulceration is a very recognized complication of using pessary. And whenever you find that there is vaginal ulceration, do not reinsert the pessary. Any sign of infection or any vaginal ulceration, reinsertion of the pessary is not advocated. Instead, remove the pessary, offer local estrogen cream for a period of 2 weeks, reschedule an appointment after 2 weeks, see whether the ulcers have healed or not, and only after that you can reinsert the pessary. Okay? 30-year-old woman who presents with moderate uterine and moderate anterior and posterior wall prolapse. She is 6 weeks postpartum after delivery with a forceps delivery, and she has symptoms of bulge and pressure on vagina, especially after she looks after a baby, and she has urinary frequency and urgency. She is sexually active, no other medical comorbidities. So what would you offer her? Okay, remember she is a young patient, just postpartum. So any form of surgical intervention is not really indicated because we don't know whether she has completed her family or not. So option C, D and E is out of question. You can choose from option A or option B. Option A, insertion of a ring pessary. Option B is insertion of a shelf pessary. Remember, she is a sexually active woman. Shelf pessary is going to occupy some space in the vagina. So a shelf pessary is not offered for anyone who is sexually active. So here option A or insertion of a ring pessary is the best option. So why is it? Because she has just presented shortly after childbirth. Though it indicates that she might have a predisposition to uterine prolapse, that would be seen at a later age. Insertion of a ring pessary right now, it is going to relieve her symptoms, and it might give you some time before she thinks of having surgery. It gives you time, or gives her time to complete her family and then think about some permanent surgical option. Okay, and you might also offer her pelvic floor muscle training as well, because she also has symptoms of stress urinary incontinence. Okay. Now next, coming to POPQ, or this is the pelvic organ prolapse quantification system. You will get questions on this. So basically in the POPQ there are 6 points that are measured at the vagina with respect to the hymen. So with any number or any point that is above the hymen, they are negative numbers. Anything below the hymen, they are positive numbers. And all the measurements, they are made at maximum Valsalva except the total vaginal length. The points that you have to measure is genital hiatus. Now this is measured from the middle of external urethral meatus to the posterior midline hymen. Then you have the perineal body, which is measured from the margin of genital hiatus to middle of anal opening, and then you measure the total vaginal length, which is the depth of vagina when point D or C is reduced to normal position. So let us see which all are the points that are there or which are measured in a POPQ system. So click on one point. So this is first point A sub A. What is this point A sub A? It is described that it is a point on the anterior vaginal wall which is 3 centimeters proximal to the hymen, and point A sub A could be -3 to +3 centimeters. The next is point B sub A. What is this point? This is a point which is the most distal position of the remaining upper anterior vaginal wall. Now B sub A could measure anywhere from -3 to total vaginal length. Next is this point C, or this is the point. So what is this? This is the most distal edge of the cervix, or if the woman has undergone a hysterectomy, it could be the vaginal cuff scar. And next you have point D. So this is the posterior fornix. It would be absent in anyone who has undergone a hysterectomy. Then you have point A sub P, which is corresponding to point A sub A on the anterior vaginal wall. So this is on the posterior vaginal wall. Again, it could measure -3 to +3 centimeters. Then you have point B sub P, which corresponds to point BA on the anterior vaginal wall. This is on the posterior vaginal wall. And again, point B sub P could measure -3 to total vaginal length. Okay. Then you have, this is your total vaginal length. This is the perineal body, and this is the genital hiatus. It's not enough knowing only what are the points in the POPQ system. You should be able to stage the prolapse as well. So stage 0 whenever all the points are in their normal position. Stage 1 is when criteria for stage 0 are not met and the leading edge of the prolapse is less than -1 centimeter. Stage 2 is when the leading edge is more than or equal to -1 but it is less than +1 centimeter. That means point A sub A, it has moved down. Normally position is -3. It has moved down. Okay. It is say -1 or it could be 0, but it is not more than +1. So +1 is when it has come out of the hymen. Stage 3 is when the leading edge is more than 1 centimeter, but it is less than the total vaginal length -2 centimeter. And stage 4, that means there is total walled prolapse when the leading edge is more than or equal to the total vaginal length -2 centimeters. Okay, so this is basically the POPQ system. You should be well conversed with all the points because you could have a lot of questions. Now pause the video here and identify the type of prolapse from the points that are given here. Okay, so if you see this graph first, point A is at 0, point B A is at 0, C is -6, total vaginal length is -8, so point C is at the normal position. Point AP is -3, BP is -3 and D is not applicable because the woman has undergone a hysterectomy. So what do you have here? This is basically an anterior vaginal walled prolapse. The posterior wall is in the normal position. Okay. In the second graph, what do you see here? AA is -3, BA -3, C is -8, AP is 0, BP is 0, point D not applicable. So here what do you have? Here this is a posterior wall prolapse. Alright. Coming to the third graph. Now what is happening? AA is +3, BA +8, C is +8, AP is +3, BP is +8, D not applicable. So this is total walled prolapse because if you see point A sub A, point AP is at its maximum. That means it is +3. Point BA is +8, so it is equal to the total vaginal length. That means the whole of the vaginal wall has prolapsed. Okay. Let us see a few questions. So a lady has presented with a post-hysterectomy walled prolapse. She is sexually active and her POPQ score is as follows. So A sub A is -1. That means she has some degree of anterior vaginal wall prolapse. B sub A is -2. Again, she has some degree because this is supposed to be -3. Point C is -1. Okay. Point C should be the total vaginal length -2. Point C -1 indicates that the vaginal cuff has really moved down too much. Now point AP, that means on the posterior vaginal wall, it is again -1. BP is -2. Point D not applicable because she has undergone a hysterectomy. Now because C is -1, it indicates that she has a very short vagina and she has come with post-hysterectomy walled prolapse. She is again sexually active. So what would you offer her? See, Macal's scaldoplasty and high suspension of the uterosacral ligaments, these two are things done at the time of hysterectomy. So they are not applicable here. That leaves us with two options: anterior sacrocolpopexy or sacrospinous fixation of the vaginal wall. Now, the woman is sexually active, so suspension of the vault to the sacrospinous ligament is not usually offered because this leads to dyspareunia, and also this is not advocated in women those who have a short vagina. So here we are left only with one option, that is abdominal sacrocolpopexy. It could either be done abdominally or it could be done laparoscopically. Okay, so remember, women, those who are sexually active, those who have a short vagina, always offer them abdominal sacrocolpopexy, either open or by laparoscopy. Whereas those women, those who are not sexually active, those who have a normal vaginal length, you can offer them suspension of the vaginal vault to the sacrospinous ligament. Now, another woman who has undergone a vaginal hysterectomy, her POPs-Q score looks like this. A sub A is +3, B sub A is +6, point C is -2, again indicates that this is a short vagina. A sub P is -2, B sub P is -3, D not applicable. So here again she has an anterior vaginal vault prolapse. What will you offer her? So you are going to offer her an anterior repair without a mesh. Remember, in UK these days, anterior vault in repair of the anterior wall or the posterior wall, it is always offered without a mesh. Okay. Now coming to post-hysterectomy vault prolapse. So there you have a 45-year-old woman who is presenting with a vaginal bulge and pressure. She has, when you examine her, you find that she has a post-hysterectomy vault prolapse following a vaginal hysterectomy and a pelvic floor repair which was done 2 years ago. She is fit and well, no other operations done, she is sexually active, she does not want to have a vaginal Pessary. So what would you offer her? Okay, you have the option of a colpoclysis, mesh repair, pelvic floor repair and sacrospinous fixation, sacrocolpopexy or uterosacral ligament suspension. So colpoclysis is out because she is sexually active. Mesh is nowadays not offered. Pelvic floor repair and sacrospinous fixation, we just discussed that it is not usually offered for women those who are sexually active. Uterosacral ligament suspension cannot be done now. The only option left is a sacrocolpopexy. Okay, so it can either be done abdominally by the open route or it can be done by the laparoscopic route. Okay, this sacrocolpopexy, remember, it is the gold standard surgical procedure for post-hysterectomy vaginal wall prolapse. This woman has no risk factors, she has no medical comorbidities, no other abdominal surgeries. So this could be an easy operation for her. Okay. Now another woman you have, she is 51 years old. She is undergoing a hysterectomy for heavy menstrual bleeding due to multiple fibroids. How are you going to prevent vault prolapse? So you can do a McCall's-Caldoplasty, you can fix the uterosacrals and cardinal ligaments to the vault, you can do a fix the vault to the sacrospinous ligament, or you can do a Birch-Kolper suspension. Okay, Birch-Kolper suspension is offered for treatment of stress urinary incontinence, so this option is not correct. Sacrospinous fixation of the vaginal vault is offered for women who have a post-hysterectomy vault prolapse, so this also is not a good option. McCall's-Caldoplasty is done when you are doing a vaginal hysterectomy. This woman is undergoing an abdominal hysterectomy, so option B is the right option for her. Okay. So the techniques at the time of hysterectomy to prevent post-hysterectomy vault prolapse. So McCall's-Caldoplasty, it is done at the time of vaginal hysterectomy. You can suture the cardinal and the uterosacral ligaments to the vaginal cuff at the time of hysterectomy. This can be done either when you are doing an abdominal or you are doing a vaginal hysterectomy. And sacrospinous fixation at the time of vaginal hysterectomy, if at the time of hysterectomy you see that the vault descends up to the introitus, but SSF only while doing a vaginal hysterectomy. It cannot be done when you are doing an abdominal hysterectomy. Now you have an old woman, 70 years old, who has a lot of medical comorbidities and she complains of a mass that is descending up to her vagina. So she has been diagnosed as having a vault prolapse. No stress urinary incontinence. She has undergone a hysterectomy 4 years ago. What would be the treatment for her? Important things to consider here. She is 70 years old. She has a mechanical valve in C2. So a lot of medical comorbidities. Remember, women, those who present with a lot of comorbidities, they are not a good option for undergoing any type of surgical interventions. Offer her a colpoclysis, which is the least invasive type of surgery that you can offer her, and it can also be done under local anesthesia. Okay. So these were the type or the typical type of questions that you would expect from urogynecology. Thank you very much for watching the video. I hope you have found the video helpful, and good luck for your exams. Thank you.